As usual, another great guest, but a quick diversion. You'll notice that our full name is the Marketplace for Health, Wealth, and Freedom. Well, let's talk about your health for a moment. If you'd like to escape from the stranglehold of insurance and be able to see alternative doctors or go across state lines for care, then you definitely need to take a look at patientempowerment.mpb.health and see if that's the fix you've been looking for. Now, let's get back to the show.
Welcome, folks, to Freedom Hub's weekly health webinar. For 4 years now, every week, I've been doing this with Jeff Cantor, who's behind the scenes these days, helping my current co-host, Jim Graypeck, design the recording so they're kosher for YouTube or at least Rumble, because we've pushed the envelope so vigorously over the years. YouTube doesn't like us very much, and if we do say too much, it won't go on YouTube, but it will be on Rumble, BitChute, and Brighteon. So they're all there, even if some great reset flunkies don't like us at times. So this is a great topic. We have had direct specialty presentations in the past, and it's new for most people because, while increasingly in every urban area, at least, if you want to pay a monthly fee, you can get the incredible experience of a direct primary care physician. There's no hassle on coming back the following week with your direct primary care physician. Sometimes they dispense drugs on premises, or they know a local pharmacist who's a lot cheaper than CVS. They know which labs to get affordable lab work, blood work. They know the specialists in the community that will do the best work for your acute problem or your chronic problem. If you are chronically sick, DPC definitely is a good deal. If you have a big family, because they're not rushed to see you in a fee-for-service reimbursement-based practice, they really get to know your problems and your mental states. You're calling them or texting them off hours. You become friends, and the doctors themselves become better. A lot of them start to explore integrated therapies to deal more effectively with your chronic conditions, which really can't be cured by pills and some of the allopathic standard care. So it's so good for the market. Your advisors for big companies are using DPC as the cost control and entry point increasingly. But what about the specialists? These specialists, they also want in on the game on cash and more time with patients. And Dr. Torres-Hodges is one of those pioneers in direct specialty care. And not every specialty works for this model, but for those that do fit this model, it's a fantastic solution. It's so good that Dr. Torres-Hodges has started a consultancy, D2P Medicus, to advise other specialists on making the jump. Some of you know Dr. Jared Wallen, who co-hosts with us a lot. He's a direct pay urologist. And I know I've had other guests present on this topic. It's a growing field. And, with the Forbes featured health plan that I sell, combining sharing and HSAs, and now the money doubling HMA, we're always looking for our partners in the provider field, the healer field, who are going to be there for our cash patients. This is how we fix healthcare on the ground. I'm also a lobbyist, so I'm doing plenty of stuff in DC for health freedom, but really the scale is going to come from the patients and the healers who go ahead and move forward with systems that work. So here's our website, your-mp.com, being shared on the screen. This is where you can find out about our webinars each week. Tomorrow every Thursday at noon is our Broader Liberty webinar, where we really piss off YouTube. But commercially, Jim runs Pavilion, the Epcot of primary care, integrated care. I sell the Forbes featured solution for small groups and individuals. We're changing the health market. So every week we want to feature our fellow leaders changing the space. And with that, Grace, it's all yours.
Thank you, Charles. Let me is the shared screen on now?
You can click it.
Not yet. Oh.
There we go.
All right. First off, thank you for giving me the opportunity to do this. I have been practicing since 2001. I'm a direct care board certified podiatrist and foot surgeon down on the Gulf Coast of Florida. I transitioned to direct care in 2017. And I'm very passionate about this because the direct care movement saved me from giving up on a profession that I truly love, I respect. I am a second generation physician. And my mission these days, first, is to serve my patients, but also now to educate not only other doctors, but just the community in general. Direct primary care definitely is the one that's more popular. And I think one of the questions that usually happens, make sure I can get my thing here. The first questions that people always ask is that, so what makes DSC, direct specialty care, different than direct primary care? Well, obviously the name, primary care being your first line into checking overall health. And then what we do as specialists, it's a higher level of inquiry when we're doing the diagnosis. And the care tends to be more episodic rather than chronic. So one of the other questions that always gets asked to me is, so how do you do a membership model? Well, because there's so many varieties of specialists, as Charles mentioned, it's not always a membership, and it's going to be based on the type of care that we're giving. I myself, as a surgical specialist, we do more of a direct consumer-based type of practice. The similarities between the two, though, is that both direct primary care, DPC, and direct specialty care, DSC, are both direct to patient. That's the main thing. And so how does that work? It's really, really straightforward. In my case, when someone wants to see me, they call my office, they make an appointment, they come in, I examine them, diagnose, treat, and they pay for the services rendered. Done. It really is that easy. And when I explain that to people, patients and also other doctors, they're like baffled. The question is, why does that interaction sound so strange? And I don't understand why a patient can't just go to the doctor and the doctor see the patient. Why do we have to have a network? Why does it have to be someone in network? Why do we need to get a second person to refer to? And as a physician, when I'm writing a prescription, why in the world do I need to get authorization to give the patient something that they need? And the authorization is being done by some third party, and usually not someone that's the doctor. The patient is in front of me. And so that always didn't make sense to me. And the way that we do things in medicine right now, from a physician's perspective, it's very tedious, it's inefficient, it's unnecessary, and in many cases, it could be even outright dangerous. So anything that gets in between me and my patient, my ability to help my patient, I consider part of the problem. And if you ask any doctor, why did you go into medicine? The answer usually is a combination of things. It's science, it's the challenge, it's a noble profession with job and financial security. But more often than not, it's the number one thing is you want to help somebody. You want to help your patient. That's the main thing. And I still remember a time, this picture from Norman Rockwell is very reminiscent of the way that you remember things were when you were a kid. You would go to the doctor. Sometimes the doctor would come to you. The doctor knew you by name. They saw you around town. They asked how you were doing. And that's the doctor that we all wanted to grow up to be. And that's the kind of doctor that most doctors want to be also. And it's the kind of relationship that can only occur if you have time and you can communicate with the individual one-on-one. And in today's world, we're teaching our young doctors are learning that. We teach them how to elicit a history. We teach them how to observe, examine symptoms, and use deduction. As far as the clinical aspects of medicine and the way we train, we have the best, brightest, and most innovative practitioners and physicians around. Very talented and quite good and very good. But the pedagogy, the way that we learn things in medical school, residency, and in some cases as we go on to fellowship, is rigorous, it's methodical, and it's very regimented. It is the see one, do one, teach one method. But when we were getting ready to step outside of academic medicine, we were told you have to get on insurance plans and networks, otherwise patients can't see you. You have to sign the insurance contracts, or else you won't get paid. We were also told, open your office, hang your shingle, concentrate on practicing medicine, and don't worry, because hire a good business person and they'll take care of that all for you. And, I fell into that trap. Many people do. And the reason why we did was that's what we're trained to do. We followed. And as far as you can see on this slide, this is what we then had to live with and deal with. We followed, and as we practiced clinical medicine, the business of medicine grew around us and changed, and patients no longer sought out the doctor directly. Physicians were now referred to as providers, and provider networks and maintenance organizations developed. Middlemen and intermediaries became the norm, and doctors started hearing terms and starting having to do things that had nothing to do with the clinical care of patients. This list is ridiculous, and I look at it, and now in retrospect, I'm so happy to be outside of that, because the once clean and direct doctor-patient relationship really looks like this. This was from when ACA came into play. It's very circuitous, it's layered, it's complicated, and it means the physician involved in medicine is dealing with more than just the patient. And where does it leave the physician and the patient? Separated in opposite corners. And this is what every doctor has to deal with right now, particularly if you're still in the insurance game. So your job as a doctor, and I address this presentation today to both doctors and also to patients, because a lot of patients don't understand what we have to deal with on a day-to-day. So, as a doctor, your job is to take care of the patient, examine, diagnose, and treat. And I love this slide because why are we putting up with it? And the answer typically from others is always like, you have to because of health insurance. And I'm here to say, no, you don't. What a doctor has to do is diagnose and treat their patient. Healthcare is what patients are seeking and what doctors are offering. Health insurance does not equal healthcare. Health insurance is just a tool to protect someone. In the ideal sense, it's to protect someone from financial catastrophe associated with the medical expenses. It's a method of paying for healthcare. It is not the only way of paying for healthcare. And unfortunately, it's not even doing its job like it's supposed to, because the number one reason why we develop bankruptcy in the United States is from medical debt associated with health insurance. So what happened? And doctors didn't realize this, that when we signed the insurance contracts, we agreed to have other people enter the exam room. And those agendas don't necessarily include you, the physician, or your patient. And it's getting in the way of doing our job. Reports were showing that even 78% of things like prior authorizations are causing patients to postpone, or worse, not even get their treatment. And then as far as getting paid for what we're doing, there's a 40% insurance reimbursement delay. Private practices are small businesses, and not everyone can float 3 months without revenue. So what do doctors do? They increase the number of patients that they're seeing each day to make up the difference. The schedule becomes hectic. The wait times are longer. Patients feel that, and doctors feel that too. They feel the pressure from that. And many of them, what they've done is they've left practice altogether. But quite a few, almost up to 70%, many have merged into mega groups or were bought out by hospitals. And your name may be on the door, you may own the corporation, but whoever sets that policy in administrative practice is actually running your business. So physician owners, think about that. Unfortunately, all of those things are just a temporary fix. Physician burnout is real. Many people are leaving the profession, and this slide is a little, actually, I just saw something this morning. It's a little bit actually outdated now, because it's more than 59% of specialists are experiencing burnout, and more than 60% of doctors aren't even recommending our kids to go into medicine. For our profession to continue, for medicine to continue, we want good people to stay in medicine, and we want to attract good people also. And it's hard to see the end in sight when we see charts like this. The green line represents a very flat line among doctors and growth over the course of the last 20 years. The growth line, though, for administration has gone up. So ask yourself, who's going to treat patients? The administrator, the reimbursement specialist, the claims adjuster. Administration is important, but there's no healthcare if you don't have doctors. But what's good is that doctors are very innovative. They're also innately problem solvers, because that's what our training is. And for many physicians, we're looking for a way out. Direct care physicians, exactly, that's the reason why we're doing what we're doing. And it's because we love what we do. Medical Economics came out with a survey in 2018 and asked what's ruining physicians' workday and what's ruining medicine for us. 70% said it. And the answer is there. Third-party interference as being the biggest challenge. And as physicians, we don't just treat symptoms, we find and eliminate the root causes, okay? So what many people don't realize is that the sequence of events that occurs in a doctor's office starts when the patient calls in. And there's a whole list of things that has to happen in order for this to occur from start to finish. And many people don't realize that this is going on behind the scenes. To break free from third-party insurers is ridiculously liberating in such a good way. It streamlines processes, it creates efficiency, and it's not just for the doctor, it's for the patient too. It diminishes uncertainty with reimbursements. It maintains a good cash flow for a practice. It saves resources, your time, your staff's time, your patient's time, and you just cut out all the minutia from it. I did this specifically with the colors. Look at the green on the right, and look at the green on the left. That's all we want to do. The doctor can get back to focusing on patient care. And for me, I didn't change the way that I practice medicine and treat patients. I changed how I interacted with the system. Patients are treated by doctors, not the insurance company. Patients should be able to go to doctors directly, and doctors should be able to treat their patients directly. And when this happens, doctors can do their job better and do it well, and it's without interference, and patients get better care. And that's what we all want. And it's care that's focused on prevention rather than being reactive or proactive at that point. It's a healthier patient as a result. It becomes more affordable because there are no other players in the mix. Price transparency with all of our prices posted results in no surprise charges in the end. And this way of practicing one-on-one, it improves communication. It gives better availability for the patient and for the physician to be accessible for them. And most importantly, it protects, respects, and restores that doctor-patient relationship. So how does that work in my practice? When it comes to office visits, you don't need a referral to come in and see me. Even as a specialist, there's no checking on in-network, no authorization for referral. The primary care doctors, even those that are still in insurance, they love this because their staff doesn't have to deal with it. And we tell the referring physicians, if you want to see me, you send the referral and we'll explain it to the patient. Let the patient contact us and let the patient decide. It's their choice. They're the ones that are receiving the care. And the nice thing is that anyone can come in and see me, whether you have insurance or not. There are no network restrictions. Now, for Medicare, the government requires you to have a private contract signed with me, but that doesn't stop me from being able to offer the best care I can. I can also still order all your tests and labs and write prescriptions. All my prices are transparent. They're listed on my website. And if there isn't something there, we talk about it. We give you a quote before I do a procedure. We give the patient a choice. And I emphasize that because that is what none of us are getting right now with third party. That's true for office visits, for procedures, for surgeries, both in and out of the office. My surgery prices even are posted. My specialty allows me to do a lot of the surgeries here in my office. But if I have to take you out, patient, to a surgery center, even to the hospital, in the surgery center, I've actually negotiated rates with the surgery center, and it's bundled. This is not something new that has been done before by other places like Surgery Center of Oklahoma, Wellbridge Surgical. Most of my patients have insurance, and some can get reimbursed for their care. So even if you have insurance and you go to a direct specialty care doctor, at the end of the visit, we can give you a receipt of what you paid for. And if you have a third party that wants to or can reimburse you, go for it. I'm not stopping you. That's great. One of the big things, reverse back here for a second, is that I always hated the fact that there was so many discrepancies when it came to third parties because they're the ones deeming what's medically necessary. In my specialty, what I deal with preventative care, something as simple as trimming toenails and cutting corns and calluses, it's covered by certain payers with a patient with diabetes, neuropathy, or vascular disease. But if you come in and you're old and you cannot move your fingers and you can't bend over, or if you've had cancer and you're high risk for infection, if you cut and injure yourself from something as simple as nails and corns and calluses, there's still a need there. That's medically necessary in my mind. And also, the funniest one was I'd have kids come in with 2 ingrown toenails, one on right foot, left foot. The insurance company would, number one, they would one time just deny it because I didn't put the right code, which is ridiculous because I treated the patient. And so we go back and we have to deal with that. But more importantly, they wanted me to have them come back for a second day to do the other procedure. They wouldn't pay for both of them at the same time. That discrepancy goes away when you drop the third party. All the inefficiencies, and I showed you on that other screen where all the office time staff is not wasted on filing and on phone calls. As a clinician, I can focus on actual patient care, hands-on the patient. I'm not spending all my time in front of an EMR. The note that we learned how to do when we were in medical school is called a SOAP note, subjective, objective, assessment, and plan. Very simple. It's for us to keep track of our patients. It's not 15 pages of cut and paste templates from an EMR. We're not dealing with that anymore. And as far as emergent care, we had this morning. I had a patient who the frozen meat dropped out of her freezer and onto her foot. And what she could have done was she could have gone to urgent care. She could have gone to the emergency room and had that checked. The ER wait, seeing the ER doctor, getting the x-rays done there, crutches, a boot, the time that would have taken for her, the cost that would have taken. What she did was she texted me this morning. I told her, come in, please. And we took an x-ray. I found out that she didn't, it wasn't as bad as we thought. She didn't need surgery. It was fractured for sure. She actually brought her daughter's crutches in. I adjusted and fitted it for her. We put her in a walking boot, made a follow-up appointment, and she's going to see me back in 6 weeks. That visit took 30 minutes. And she went back to work. That type of efficiency is what we can offer. And perhaps the most important thing with regards to direct care and what the benefits are was seen during COVID. I prematurely put this slide up. This is me doing a house call, okay? Because we could adapt to things. Direct care doctors, in the midst of all the March 2020 shutdowns during COVID, we were still functioning because we could contact and we could stay in contact with our patients. Telemedicine is not a new concept to folks that are in direct care, whether it's by phone, by email, or a video online. I could follow up with my patients, whether they had ulcers, whether I had to do procedures on them. I could visit with them. I redid the home visits. Continuity of care, it doesn't stop. So as you're listening and to this, you're wondering, so how does direct care work for you? in this situation. So let me tell you, from a patient perspective, it coexists with traditional third-party payers right now. I put this slide up because auto insurance makes sense to most people. Think like you would with your auto insurance. You don't go and use your auto insurance to pay for gas, wipers, or oil changes. And if you have big ticket items like transmission or AC repair, you get an estimate and you shop, but you get to choose. But if you have an accident with major damage, the insurance is there to prevent the catastrophic financial risk. And that's really that's how insurance should be. Keep in mind, the majority of my patients and those that see direct care doctors have some kind of third-party payer, and they've kept their plans. Most, though, have high deductibles. And many times the cash price may be cheaper than the copay or the co-insurance. The emphasis again on this is on outpatient care. And overall, if we start doing this regularly, healthcare expenditures can go down. Outpatient care is much more proactive and preventative. Patient involvement, putting the onus and responsibility and the accountability on the patient makes them aware of what they're doing and how they're spending their money on things. And the outcomes are healthier. My patient panel now as a direct care specialist is much healthier than what it was when I was still on third-party payers. And by steering this care away from urgent cares and hospital admissions, you avoid using and overutilizing the more expensive services. You actually clear out your ER for real emergencies that need to be taken care of. And the direct interaction with the doctor's office allows for creative payment plans. Our services are bundled. The prices are all listed. Payment plans can be arranged. And in our case, when we do a month-to-month payment plan, we can do it, and there's no interest on that. And we can still barter. That's an old way of doing things. And so I have some patients that can't afford to do it if it requires me to have my logo was done by a patient. That type of thing, you can barter still. So there's a lot of open opportunities. And so doctors, when you're thinking about, can I do this? Yeah, you can. For those who are contemplating transitioning to this model, you don't have to go all in at once. You can test the waters and start hybrid. You really have to look at your numbers and figure out your payment reimbursements. But the beauty about direct care is that any doctor, any lab, any facility can participate this. All a patient has to do is ask, what's your cash price? That's it. And what's cool is, and this is from a recent publication by Hint, you can see that there is a need, want, and interest in this. This is the Google searches for direct primary care, and direct specialty care always lags a little bit behind. The findings, though, you could see it was increasing as time went on, but there's still about 68% that just haven't heard of us. So we've got a lot of work to do, but I can't emphasize enough how direct care, and in my case, direct specialty care, is the way to go. It empowers patients and physicians with choices. It's patient-centered care it's available. The delivery, it makes it all accessible. The price transparency makes it all affordable, giving the patient the choice. And above all, it maintains and respects that doctor-patient relationship. And that's why I practice it. That's why I promote it. That's why I believe in it. I've put on that last screen also there how to contact me. Patients, start asking your doctors about this. If you really want to, it's a relationship with the doctor and the patient. If you want to help your doctor, this is what's this makes a big difference. And doctors, consider that. Who are you working for? You work for yourself, and you work for the patient. You don't work for the third party. And you think it through. And it's amazing to see what happens when you unplug from this whole system. And that's all I got today. But I'm open to any questions here. And I hope that helped.
That's great, Dr. Torres-Hodges. I think Dr. Wallen is available if he wants to unmute himself and talk about his direct urology efforts, and maybe you can show off your chops, Dr. Torres-Hodges, and show us what your consulting practice would say to him. Dr. Wallen, are you
Yeah.
there?
I'm gonna
Yes,
unshare that there.
Thanks
Is
so
Jared
much,
on?
Dr. Torres-Hodges, for what you shared with us today. I think that's very important. I guess my initial endeavor into direct specialty care has been a little bit difficult just because of trying to get, lined up with surgery, especially from a surgical standpoint, with surgery centers and hospitals. A lot of times they want you to be in contract with Medicare and what have you. So I guess if you could comment on how you worked around that, but also I think, one of the things that a lot of our colleagues don't understand or don't know is the financial side of medicine. And so how did you come about your pricing structure and get that to be able to, provide value and still generate enough revenue to keep your lights on, so to speak? And then a third question for you would be just in regard to anything that you did to potentially broaden your offerings or broaden your skill set to kind of be able to generalize your offerings to patients.
Okay, all good questions, and ones that we hear all the time. Let me address them one by one. The surgery issue, that's a big one that a lot of people always come about. One of the things that the first insurance companies that I dropped were the private insurance companies before I dropped Medicare. So again, I tested the waters first by dropping, this is more technical, I guess, for our physicians, but it's good for everyone to know what's going on here. I dropped my private insurance carriers first. And by doing that, I was able to already begin with surgery centers, talking to them about, okay, what I'm going to charge my patient this. I never worked for a surgery center. I never worked for a hospital. So patients were always getting my surgery fees as a separate fee altogether. They would be responsible for paying for it by itself. There are 3 fees for most people that, if you don't understand this, when you go in for outpatient surgery, there is a surgeon's fee, there's a facility fee, and there typically is also an anesthesia fee. The anesthesia fee sometimes could be bundled with the facility if the anesthesiologists work with them. It depends upon the state. So surgeon fee, giving that to the patient directly, that they learned how much that was, that kind of tested the waters. This goes into your second question about price structures. You have to know your market. You have to know what patients are willing to pay for and what the rates are. For surgeons, I would highly recommend contacting and talking with the folks at Surgery Center of Oklahoma, and also now Wellbridge Surgical, which is a freestanding surgery center in Indianapolis. They've done this, and I use their techniques of talking to the surgery centers to ask, now, if I want to bring this patient over here for a bunion, can you give me a rate of rental for the room and also anesthesia? I bundle that together, and then that's the price I offer to the patient. In the hospital, I still do occasional procedures in the hospital. The patient can still use their insurance there for facility. We try and steer everybody outside of that, outside of the hospital. But if we have to do something in-house, gangrene, amputation, something like that, again, it's a separate fee for me. And then let them, they'll go through the process of getting the facility and anesthesia covered that way. If they have I would still ask them and tell them, ask for the cash price, because they would be surprised with how different the cash price for facility and anesthesia, and even in a hospital, is compared to what it would be, the self-pay price would be if they had to file it through insurance. As far as pricing structure, it's much easier now. I dropped a Medicare in 2017, and the environment online right now with regards to cash services and the availability of doing price comparisons is night and day. So you can actually go online. I would, as a physician, you look at your CPT codes that you've been filing currently under your third party. You look and see what all your payers are and what your reimbursement rates are. And you have to find the average in there. Then you ask, I had a lot of time, a 3-year gap between the time I started dropping insurance and also dropping Medicare, to talk to patients. I still talk to patients. I ask them, they are very aware of what prices are around town. But again, using now online, we have a lot of opportunities to look at prices based on CPT codes. You can look it up. And then just ask what works for your area. I live in a, it's suburban, we're on the Gulf Coast. I have a lot of retirees. The idea, I think my area of Florida, well, Florida in general, we have the highest percentage of seniors, higher percentage of Medicare, but in my area, we have a lot of military also. So we have Medicare and TRICARE, Champus, and all the those federal plans that patients have. But it's amazing. They realize the quality of the care that they're getting, and it's not the doctors, it's not their poor treatment. It's not that, it's the fact that the system is so broken, but they find better value in what I'm offering for them. So as far as surgery center, I hope I answered that. Price structure, I hope I answered that. As far as broadening my skill set, you find niches. You have to find, this is a business, and that is probably the hardest thing for a lot of doctors. And Dr. Wallen, you and I share now that we're both MBAs, and so it's sometimes hard to explain. I actually went back to school to get my MBA to teach business to doctors, because this is not something that's taught to us in school. We look at things so narrowed, and because of that regimented way of looking at things, we need to be able to look outside of the box, or not even use a box. We broaden it by, I did more pediatric things. You look for niches. I do minimal invasive surgery. You know, a lot of other doctors can also go into more alternative treatments. You know, a lot of wellness programs. You know, so it's out there. You have to be, you cannot just sit. If you are going to direct care, I will say this first and foremost, if you are going to be a direct care physician, you've got to work at this. This is not going to fall into your lap. Our young residents, you know, when we were in school, when we're in residency, when we're in med school, we're competing. And then we get lackadaisical. I don't know what happens to us. 11 years, if you count undergrad, if you count medical school, if you count 3 years of residency minimum. And then there's those that go further on to further residency and also fellowship training. Somehow or another, we just got used to doing things a certain way. You got used to the system. We got to break out of that system. You've got to be hungry with this again, because that's the only way that we're going to save our profession. You know, we want good people to stay in medicine. We want good people to be attracted to it. So I hope that answered your question.
Dr. Wallen.
Yeah, awesome. Thank you so much.
Dr. Wallen, unless you're seeing a patient, has direct payment expanded your urology services to beyond the old standards of care?
Yeah, I mean, I think by and large, you know, certainly I know Mark Aubrey's on this call, and regenerative medicine, you know, there's a big overlap with urology and hormone replacement or hormone optimization therapy. You know, I think that is something that is not necessarily taught well, quite honestly, maybe in any training program other than possibly endocrinology. And even there, I think that they potentially fall below the standard of actually optimizing people. So that's one thing. But even beyond that, you know, Dr. Torres-Hodges mentioned an alternative care, you know, PEMF for blood flow and vascular issues, but also bone pain and other things with that. For those not savvy, it's pulsed electromagnetic field. I mean, I think the electromagnetic field of the earth has decreased approximately 50% in the last 300 years. So, you know, trying to find a way, we are electric beings, and all of our functions basically happen through signals that are conducted via electricity down our nerves and what have you. So, you know, that is something that is certainly been beneficial to patients. You know, beyond that, I think just broadening my education and getting into anti-inflammation and dietary stuff, you know, the microbiome, the more we learn about it, is so important for a lot of your health, your sleep, your mental, your, you know, immunity. Certainly with COVID, people have heard about, you know, vitamin D and such, and even to some extent vitamin D supplementation. I mean, to a large degree, I think in the past, most folks would say, you know, between 30 to 60 nanograms per deciliter is probably, you know, where most folks should be. But I think there's more evidence that's coming out that, you know, possibly even higher than that, up to 60 to 80 nanograms per deciliter is important, especially for immunity functions and such. So I think those are kind of the main things, I guess obviously there's kind of along the hormone optimization timeline, the peptide therapies and that type of stuff, which is, coming out there. And I know, Mark promotes a lot of that stuff with regenerative health management, his corporation there. But I think even, for folks that have more interest in kind of that regenerative side or what have you, or things you can do kind of to branch out. I mean, I think even a good place to start would be Tony Robbins' new book, Life Force. When he interviewed 170 some Nobel laureates and scientists and doctors throughout the world, and basically kind of came up with a 700-page, manifesto of all the stuff that's potentially out there now, but even just the stuff that's coming down the pipeline for managing and when we look at it, it's not only increasing your lifespan that matters, it's increasing the number of healthy years that you're on this planet, right? And obviously, even just looking into your food sources, whether it's your water source or wherever you're getting your meats, antibiotic free, hormone free, what have you, and even just all the pesticides that are laid on a lot of these vegetables and such that could potentially be harming you, right? So there's a lot of knowledge, general knowledge on the surface, but you start to dive deeper into a lot of these things, and you have to be careful. I mean, for instance, you look maybe 20 years ago, a lot of people thought bottled water was great, right? But I mean, there's a bunch of companies that are just repackaging tap water from other places. So, again, the tap water in a lot of our communities is not, unless you're running it through a heavy metal filter and what have you, is not all that great for you to some extent, which, water is also, but it's 70% of our body. So it's very important for our overall health. So I think those are kind of the main things that I've tried to dive deeper on to truly expand my offerings to folks and provide value to them.
That
The
was
key
a
thing there,
mouthful.
yeah, the key thing there is that it shows it's preventative care. It's trying to, and putting patient responsibility. One of the things that I've always said with direct care is that when a patient doesn't have to pay for something, you don't appreciate it as much. And then that's not just patients, that's just true. That's how we taught our kids. If you have to work for it, you'll appreciate it more. That's kind of the same thing here. So the fact that Dr. Wallen's doing all those things, everything is proactive, preventative, and putting it also on the patient to be responsible. There was a question that came on the chat. How much do I incorporate?
Linda will ask that question soon.
Yeah.
So we can pause on that. Jim, you were going to say something, or we can go to Sam's got his hand up. Jim?
No, nope, go to Sam.
All right, Sam.
Oh, I would just say, Grace, I think we should appoint you to head up HHS. And,
No, that's okay.
and fix the system. Great
I'm
presentation.
going to take care. The thing is that as doctors, we take care of our little area. This is true grassroots. You take care of our area and we build from here. I will work with what I have where I'm at, and that's what it is. And so I appreciate that though, but no.
Sam, go ahead.
Hi, Dr. Grace. Thank you very much for sharing. My question is about how do you attract patients? How do patients find you? And the reason I ask this question is because, as you mentioned, very few specialty practices are now independent. And I think that applies more to primary care practices in some way, shape, or form. They're all, somehow part of a health system, and the referrals sort of float within the health system. And so I believe the onus is really on the patient to break out of it and find practices like yours that offer different value proposition and different types of services. So how do you actually attract these patients, or how do the patients find you?
Well, good question there. I deal with patients, or excuse me, I deal with doctors. I work with doctors who are new, fresh out of residency, and I also work with seasoned doctors. And I'll start with the seasoned doctors. Myself, I was 15 years in practice already by the time I decided to go direct. For those of you who have already established yourself in your community, take advantage of that. And then you start showing through your work and with the time that you spend with them. I am not rushing them through 7 to 10 minute visits. I'm spending 20 to 30 minutes with them, going that extra, the little extra mile for them. The word around town and word of mouth, that's going to be your biggest thing. You start with one family member and you can expand from that. And it's just, it moves quickly that way. For new docs or for someone that's like leaving employment and starting fresh, for those that have been existing already, we remember when we first opened up our shop, you didn't have that many patients. You could go to, you put yourself out there, you go to civic groups, you talk and find niches that were associated with your specialty. I'm going to use podiatry as mine because I'm able to go to daycares, talk about pediatrics. I can go to sporting events and talk about sports medicine. I can go to senior homes and talk about geriatric feet, bunions, corns, calluses. So in your own specialty, who are your patients that are coming in. Reach out to them, find groups that you can speak with. You have to market yourself that way, and then just build slowly. Be frugal when you start. This is a business. And again, going back to that thing that we weren't taught in school, you have to treat it like a business. There is revenue and there is income and expenses. You need to know how much it costs to put something out and how much you need to take in order for it to work. And so don't try to, I think what happens is particularly those that are attracted to the bigger salaries when they're proposed an employment contract coming out of residency, it'll pay everything for you. We'll put you in a house. They're giving them like the world, but you're going to also be handcuffed to them forever. You be frugal. That's the best thing I can say. You have to know, again, read your market and know. Work with other doctors. You will, if you're seasoned still, you'll use your same referral basis. The fact that I don't need to have a authorization, I talk to my referring physician staff. They love that because they don't have to wait on the phone. They don't have to call. They don't have to get numbers. They just give my name to the patient. That's it. And we make the appointment. That's it. And then you let the patient decide. So that's, it's just, you have to put you have to just do your work.
Okay, in the last 10 minutes, we're going to try to sneak in some quick questions and quick answers here, Dr. Torres-Hodges. Michael.
Sure.
Hey there, Michael Wigginson, Colson Director with Americans for Prosperity, focused on building out the personal option. Wanted to know, one of our concerns is about COPN laws. In Virginia, there's COPN laws. In other states, there's certificate of need laws.
Oh.
I just wanted to know what is the impact is there an impact in like CON laws in different states for direct primary care like surgeons or other specialists?
It would, the only area that I know of with regards to, and it varies from state to state. One of the things that I've been in contact with Surgery Center of Oklahoma and also the Wellbridge Surgical is trying to figure out how we can do that here in Florida. We'd love to be able to do it. Like you said, you're in Virginia, you said, yeah. So, the certificate of need, as far as a surgeon is concerned, I do cases in my office. A lot of surgeons can do cases. I think Dr. Wallen can probably do some in his office. Plastic surgeons do it in their office. Dentists do it in their office. We can do a majority of our cases in office. We can do that, and then that's fine. But when we start having to do surgery center type of procedures, if there is a certificate of need, the restriction, that becomes that's what we have to always pay attention to, because we'd love to be just like open up. That'd be nice. I don't know enough about it myself. That's not my thing, but there is, as far as what you're talking about, yeah, if we could just get rid of all that, that'd be fantastic.
Yeah.
But but a lot of doctors, particularly surgeons, we can do procedures, dermatologists, plastics, podiatry, even ortho and in the family practice, our DPC doctors are doing lacerations and sewing things up in their office, doing biopsies. So yeah, you don't have to bring everything to the emergency, to the surgery center. You don't have to bring everything. You know, it's always based on clinically what's needed.
Thank you.
Welcome.
Yeah, Jim, I think your pavilion has that as an idea that if we can repeal the hospital's protectionism against competition, we could build more humane hospitals, because COVID really made people pissed off about the whole top-down politics of the hospital and their limitations. So I think we want better institutions for all levels of care, Dr. Torres-Hodges. Linda?
Yes. My question is, how much you will incorporate digital medicine in your office, or you will fight against? Because I have been through medical digital medicine conferences, and the internet is the most unpredictable way of communication. Also dangerous for our health, EMF, 5G, wearables, and things like this. But it will soon be imposed to you and to us as patients. And as a human being, I need a human being doctor. And I have the right to receive healthcare without having a cell phone on me. Do you understand that? And to see you what will comes very soon. Just watch the Davos with the WHO and the World Economic Forum conference is the annual 2022, which is right now. You put WEF 2022, and you will see all the lectures, which are scary. Genome modification, dangerous vaccine, all that. How we are going to survive and to fight this criminality, please. Because you are so sensitive, you want to do a good job for the health of people, but others, they prepare something criminal. How you're
Grace,
going to face that?
before you answer, Grace, I just want to jump in and say, I think we have to look at this whole system, the whole Davos thing, the whole takeover of the public health in the world as something that is going to go away in the next couple of months. I think it's going to be a mess, and people are going to rise up and get rid of it, because there's no way we can practice healthcare with criminals running the system. Anyway, sorry. Go ahead.
Okay.
I think the question, Dr. Torres-Hodges, is about the digitization of some of the healthcare and the apps and all that stuff.
Yeah, in my own practice, I don't do that. The remote, like a lot of the remote patient monitoring, I think that's one of the things that I'm not familiar enough with the entire industry with that. As far as, when it comes to direct, I think the biggest thing for me to explain with direct care, it's a hands-on type of thing. That's what we're trying to push. There are certain specialties that you can't do things digitally. So my apologies, Linda. I don't know enough about what you're talking about to really make a comment on it one way or another, except that, for me, my most important thing is the patient that is physically in front of me. I will use a video chat with them if they are unable to get to my office. That's the extent of digital that I use. My patients who are diabetic that have ulcers, to avoid them from walking on it, I use that. As far as monitoring, my staff calls my patients to check on them. We don't rely on it digitally with it. One thing though, you can't stop what other people are trying to do. And the way that I look at digital, as far as direct care is concerned, the movement itself is almost like, I'm going to liken it almost like to education. How we have we have people that go to private schools and homeschool, and then there are people that are in public schools. There's going to be a public way of doing medicine, and I think there's going to be a private way of doing medicine. This is one of the private ways of doing medicine. And you know, COVID kind of opened up a lot of eyes to people to realize that there are people that still want to do medicine this way.
Thank you so much.
welcome.
God bless you. I
Okay,
hope that you
Linda, we
will
have to
be
move
able
on.
to continue.
Thanks, Linda. We have to move on. Mark, go ahead. We're almost out of time.
Just a couple of thoughts. I've been working with doctors for 20 plus years on the business side of things, and Dr. Torres-Hodges was a great presentation. I think that you're doing a great deed to your fellow doctors. The biggest one is, this is a business. If you don't look at it as a business, you're going to fail. It's that simple. And then looking at it as a business, you have to provide value. If you want to get people in the marketplace, you have to actually provide value beyond what they can get by going to their insurance provider. The two last things I'll say is, if you're not incorporating telemedicine into your practice, you're going to get left behind, because that's a matter of convenience for people, and people like the convenience. They like to do both. They like the personal touch, but they want to be able to have that telemedicine access. The last thing I'll say is, and Dr. Torres-Hodges, you pretty much hit on this, is that you have to, if you're a physician or a healthcare worker or health professional, you have to put on your own oxygen mask first. Take care of yourself first. You've been told your whole career that you have to give everything to everybody else. If you're not taking care of yourself and taking care and doing some self-care and figuring out your business stuff first, everything is going to fall apart from there. So great job. I enjoyed the presentation.
Thank you.
Thanks, Mark. Last question, Sam.
Yeah, this is a quick one, Charles. I'll keep you on schedule. Dr. Grace, one quick question. You mentioned that cash pay can be reimbursed by insurance, or at least applied to as a deductible. How often do you see that happening? Because I believe that's at the discretion of the carrier to accept it or not.
That's correct. And it's whether or not the patient actually has out-of-network benefits. What I've found is that a lot of my patients do. And so why not? I want them to get reimbursed if they can. They've paid into that premium, but if they can get it, it's at the discretion of the patient contract. What I've also found, though, is that there are a lot of patients, because they seek me out as a direct care specialist, who have alternative type of insurance plans that are more direct reimbursement, sharing plans, and other types of again, direct reimbursement type of plans that they're able to do this. So you're right, Sam, that it is at the discretion of what the patient has.
Thank you.
And thank you, Dr. Torres-Hodges. Do you want to give a closing statement and tell folks how they can reach you?
Sure. I hope someone gets even one little pearl from this, both physicians and also our patient communities out there. If you need to reach me, I am online through Facebook, LinkedIn, Instagram, and Twitter at Dr. Grace DPM. My consulting firm is called D2P Medicus, and my practice is Torres-Hodges Podiatry. And thank you again for inviting me today to share my thoughts.
So what about your wealth? If your money could actually talk to you, would you listen to it? Well, with the DNA Network Academy, your money actually can talk to you. And it's going to tell you just what it told this client. This family had over 24 debts, mortgages, car loans, the works. They were on track to take 20 years to pay it all off, and instead did it in 8.5. Plus, they did it without refinancing, making more money, or even changing their lifestyle. So find out for yourself with a free analysis that is completely confidential. No personal information, no social security numbers, no credit checks, none of that nonsense. But what is exciting is that the outcome of that report you receive is a guaranteed outcome for you. To get that report, head on over to bit.ly/debt to wealth. You will arrive at this simple form. Fill it in, as simple as lender number 1 and credit card number 2. What really matters is the accuracy of your numbers. You'll be able to see that if instead of 20 years or whatever your number is, that you may actually be out of debt and on your way to wealth in as little as 6.3 years like this client.